topic for my two-way presentation is retinitis pigmentosa. Retinitis pigmentosa is progressive degeneration that typically starts with the involvement of rod's photoreceptor followed by cone's photoreceptor. Thus, it is classified as rod-cone dystrophy. Although retinitis pigmentosa usually affects the eyes, it can also occur as a part of syndrome and result of systemic condition in 20 to 30% of cases. The most common syndromic association is Usher syndrome, in which RP is accompanied by hearing difficulties and possible vestibular ataxia. Global prevalence of RP is 1:5,000. Approximately 50 to 60% of RP are inherited in autosomal recessive pattern, 30 to 40% in autosomal dominant pattern, and 5 to 15% in autosomal X-linked pattern. History. A 60-year-old female presented to IOPD with complaint of gradual progressive painless diminution of night vision in both eyes for 2 years and peripheral visual disturbance with no aggravating or relieving factor, and it is not associated with pain, watering, or any other discomfort. The past history was within normal limit. There was no family history of similar illness in any of the family members. There was no significant history of drug or any other prolonged topical eye drops. General examination, all the parameters were in the normal limit. In systemic examination, everything was in the normal limit. Ocular examination, both I had cataract, thus the vision was finger counting 1 and finger counting 1 in both eyes. The best corrected visual acuity was 6/36 for the both eyes. Rest anterior segment was within the normal limit. Due to the cataract, the media was hazy in the both eyes. The color of disc was waxy pallor. The disc shape was normal. CDR was 0.5 and 0.6 in respective eyes. Vessels was attenuated and bony spicules in all the quadrants in the periphery was seen. Foveal reflex was dull. Confrontation test was done, which shows restriction of visual acuity in the peripheral quadrant. Color vision was intact in both eyes. Contrast sensitivity was reduced. Perimetry couldn't be done as the patient had poor fixation, making the reliable field mapping very difficult. The diagnosis was clinically evident and classical fundus features and OCT findings, hence the ERG was not done. This is the OCT of both eyes. This OCT shows there is macular sparing with no macular edema. Based on clinical finding and investigation, diagnosis of both eye retinitis pigmentosa with macular sparing was made. Management, proper counseling of patient was done. In medical management, patient was advised to take 15,000 international unit of vitamin A with regular follow-up to prevent vitamin A hypertoxicity. For surgical management, patient was advised for cataract extraction surgery, and the patient was further advised for visual aids, rehabilitation training, and genetic testing.